So thank you. I'd like to take a few minutes today and tell you a little bit about the research that we've been doing around the COVID-19 pandemic in the Canadian Vigor Centre, the Alberta Spore Support Unit, and in collaboration with Ontario investigators at the Institute for Clinical and Evaluative Science at the University of Toronto. Now, through the COVID-19 pandemic, we've all grown very used to hearing terms about the waves, the first wave, the second wave, the third wave of the pandemic. But what I'd like to show you on this slide is actually a different way of thinking of it. And this is really looking at the COVID-19 pandemic in three real different waves. So there's a first wave, which is really the primary impact of SARS-CoV-2 infections. And this is the acute morbidity and mortality that we see in the COVID-19 pandemic. The next wave, which is larger than the primary impact wave, is the secondary impact. And this is the impact of deferred and delayed chronic disease management due to healthcare restrictions that were implemented with the best of intentions at the initialization of the pandemic. And also those secondary impacts arising from changes in outpatient care patterns, reduced presentations to emergency departments, hospitalizations for non-COVID conditions, and just the impact of the COVID surges in the inpatient and diagnostic imaging capabilities. And then finally, the third large wave that we see in this slide is the tertiary impact of the COVID-19 pandemic. And this is really the influence of the pandemic-related psychosocial and economic factors and all the deferred primary and secondary prevention that happened during the pandemic. So really, when we talk about the primary impact of COVID-19, we now know, and we can see on this slide, that there's been an increase in excess mortality in Canada and actually in 191 countries around the world from this recent publication in Lancet just this month, in fact. And this is showing about between 15 and 25% excess all-cause mortality in all countries measured, except Australia, China, and New Zealand. Every other country had an increase in excess mortality. It's estimated that so far over 18 million people in the world have died during the COVID pandemic that wouldn't have been expected to die otherwise. And importantly, about half of those individuals were actually between the ages of 25 and 64. And again, importantly, between a quarter and half of those individuals had no evidence that they ever had a SARS-CoV-2 infection. So really, while yes, there may be some under-testing, particularly early on in the pandemic, what we do know from that is it looks like a lot of the excess mortality, perhaps as much as half, was related to non-COVID diseases. And a big player there, of course, is cardiovascular disease. We see on the next slide a nice summary from the NHS in the United Kingdom showing that although cardiovascular deaths in hospital decreased during the pandemic, cardiovascular deaths at home and in long-term care facilities increased substantially, so that overall all cardiovascular deaths were actually up quite significantly in the United Kingdom during the course of the COVID pandemic. We have similar data that's now come out from Ontario and from Alberta, showing that the excess mortality, again, about half of that excess mortality is in patients who had no evidence of SARS-CoV-2 infection and was actually related to cardiovascular disease, opioid overdoses, increased rates of mental health and cognitive disorders. One of the major foci of research that we've been pursuing within the Corona collaboration between ICES and the Canadian Vigor Centre and the Alberta Spore Support Unit is to look at outpatient ambulatory care patterns. Prior to the COVID pandemic, in order for a physician to bill for seeing a patient, they had to see them in person. Of course, in March 2020, after the pandemic onset, very quickly, healthcare systems throughout the world pivoted to offering virtual care that was remunerated for the physicians and allowed the physicians to see patients by telephone or by video conference link rather than in person. We do know from some research we just published in medRxiv just 2 weeks ago, that 41% of outpatient visits in Alberta in the first year of the pandemic were actually done virtually and not in person. Now, there had been some evidence from the United States suggesting that patients who were seen virtually were much less likely to have their cholesterols measured, their blood pressures checked. They were 50% less likely to have medications optimized. So we decided to actually use the Alberta data sets to look at what were the outcomes for these individuals after virtual outpatient visits versus in-person outpatient visits. And as you can see from this slide, and again, this is preliminary data published in medRxiv, so it hasn't been peer reviewed yet. We found that within 30 days of an outpatient visit, if the outpatient visit was done virtually, people were 11% less likely to present to an emergency department, be hospitalized, or to die than if the visit was in person. Now, again, we can't assume causation here because it's observational data. It's just an interesting observation that outcomes were different for patients depending on whether they were seen virtually or in person. And on the second side of the slide, you can see another histogram showing the 90-day outcomes where there was a 7% less health resource use in individuals who were seen virtually versus in person. So there have been large changes in the healthcare system in Alberta, in Ontario, throughout Canada, brought on by the COVID-19 pandemic. And we're starting to do some some analyses now to drill down into the data to find out what the impact of those effects were. So I just want to close with that slide again to remind you that of the COVID-19 pandemic, the SARS coronavirus 2 infections were really just the beginning, that primary impact, the acute morbidity and mortality. And in fact, the secondary impacts and the tertiary impacts of the pandemic are much larger and of great significance for patients with cardiovascular disease. Thank you for your attention.